We'll give it another minute or two. I think people are still trying to log in, and they're slowly coming in. Okay, I will get started, and I think people will just log in whenever they can. Welcome, everyone. So I'm thrilled to have you here for our inaugural event of the Graduate Student Knowledge Base's Women's Speaker Series, Women in Academia. This webinar series is meant to provide a platform for women in academia to share their experiences, insights, and advice with the next generation of scholars. Through these sessions, we aim to foster a supportive community where graduate students can engage in meaningful dialogue, gain inspiration, and build connections that will help them navigate the unique challenges and opportunities in their academic careers. The Graduate Student Knowledge Base, an initiative by the Assyrian Studies Association, was designed with a clear mission: to be a beacon of support and guidance for graduate students. From mastering research methodologies to navigating the ups and downs of academic life, this platform is here to foster collaboration, provide essential tips, and help graduate students thrive in their academic careers. Today's webinar is part of an ongoing commitment to empower and uplift our graduate student community. By bringing together esteemed voices in academia, especially those who have navigated the unique challenges faced by women in the field, we hope to inspire, educate, and provide practical advice that our audience can take forward on their own journeys. We believe that through these shared experiences and insights, we can contribute to a more inclusive and supportive academic environment for all. If you take inspiration from today's webinar and would like to be part of our future events, please visit our website, graduatestudentknowledgebase.com/contact to submit your inquiry. Before we get started, I'd like to remind everyone to use the Q&A feature at the bottom of your screen to submit your questions for Dr. Shameran Slewa-Younan. After her presentation, we'll have a dedicated Q&A session where we will address your queries. In addition, this webinar is recorded and will be available at both our Assyrian Studies Association and Graduate Student Knowledge Base websites, in addition to our YouTube page. If you're interested to stay up to date about future events, both online and in person, make sure to sign up on our websites, ASA and also Graduate Student Knowledge Base. If you are a graduate student here, make sure to become a member of the Graduate Student Knowledge Base to keep track of all events, grants, and much more. It's free to register, and it's filled with resources meant to help you along your academic journey. Now let's move with today's program. I'm especially honored to introduce today's distinguished speaker, Dr. Shameran Slewa-Younan. Dr. Shameran Slewa-Younan is not only an associate professor of mental health at Western Sydney University's School of Medicine, but also an honorary senior research fellow at the University of Melbourne's Centre for Mental Health. Her research has been nothing short of transformative, advancing our understanding of mental health and trauma along refugee communities. With over 60 peer-reviewed publications and numerous accolades, Dr. Slewa-Younan has established herself as a leading scholar in the field of cross-cultural mental health. But beyond the impressive achievements, she's a passionate advocate for mental well-being and some of the world's most vulnerable populations. As an Assyrian female academic, her story resonates deeply, highlighting the resilience, determination, and strength it takes to succeed in academia as a minority woman. Today, we're not only fortunate to hear about her groundbreaking research, but also to gain a glimpse into her personal journey, one marked by perseverance, dedication, and unwavering commitment to making a difference. So without further ado, please join me in giving a warm welcome to Dr. Shameran Slewa-Younan. We're grateful to have you today.
Thank you, Alexandra. Thank you for the warm welcome. Okay, so I'll just quickly start by just going through a couple of things, I guess, housekeeping and things we need to kind of do. So I'd like to begin today's talk by paying my respects to the Indigenous people on the lands from which I'm giving my talk, and that is the Tharawal Nation and their ancestors, who have been the traditional owners of this country for tens of thousands of years. Western Sydney University would like to acknowledge and pay our respects to elders past and present, and we'd like to thank them for their support of our work on their lands and beyond. We acknowledge that their teaching, learning, and research that takes place on these campuses continues the many thousands of years of education that they have has occurred on these lands. So I was asked today to talk a little bit about my research and the journey, I guess, that I've taken as a female academic and some of the experiences I've had. So I have divided today's talk into two parts. I'd like to kind of initially talk a little bit about the research, so an overview, really kind of a bird's eye view of the research that I've been involved in. And then I will talk a little bit about myself, who I am, I guess, just to give a bit of a background and some of the attributes or strategies that I found have been helpful over the years to try and cultivate, I guess, if you are interested in staying in the field of academia. But because I know that probably a bulk of our audience, maybe all of our audience, is not from Australia, I wanted to give a bit of a context as to where Western Sydney sits in the university itself, just so you can understand the research and how it's linked to our university. So Western Sydney University is a multi-campus university. It is a public research university and it's located across what we call the greater Western region of Sydney. It stretches over an area of around 9,000 square kilometres of both kind of regional and residential and rural lands. And it is a very young university. It was founded in 1989, so it's not very long at all. And it serves around 47,000 students. Almost half of our students are the first to attend university in their families. And the diversity of our students is very high, which really reflects the region that we're working in. And when I mean diversity, I'm talking about culturally and linguistically. As I said, it was founded only 35 years ago. However, it has since then gone on to receive a number of accolades, such as being #1 for its commitment to the United Nations Sustainable Development Goals, such as reducing inequities, and it is amongst the top 50 young universities in the world. So I'm based at Campbelltown campus, which is here. You can see, I don't know if you can see my mouse, hopefully you can. And this is where the School of Medicine is sitting or situated. And School of Medicine itself is quite a young program. We had our first cohort in 2007. So you can see it's been a very kind of short, but really, really fast trajectory in terms of the accolades that university has achieved. So Alexandra mentioned that I'm an Assyrian by background, but I'll just talk a little bit about my background in terms of being a psychologist. So I have been a psychologist worked in the clinical space, transcultural space for a number of years now, probably more than I'd like to admit. And in those years, I've been part of what is a very unique public health service. So it's called the New South Wales Transcultural Mental Health Service. So New South Wales is a state of where Sydney sits in. And so this is a statewide service. And the service really is there to help both community members and health professionals in assisting and supporting the mental health needs of cross-cultural populations. So it can be refugees and newly arrived people all the way through to second-generation migrants. In addition to this work, I've also been part of a medical centre sitting in Fairfield, and this is the city of Fairfield. I don't know if people realise that Fairfield is one of the kind of highest, the top 3 ancestries in the most recent census, 2021, was Assyrian, Vietnamese, and then Chinese. So by far the biggest bulk of Assyrians reside in Fairfield in New South Wales. So I've been working in this clinical space, as I said, for many, many years now. And what I have found is that when I was working in this space, I was noticing a particular pattern. And it was only when I then moved over from the previous university where I was doing my postdoctoral work to this current university, Western Sydney, that I decided to both kind of connect my research and my clinical work. And it was then that kind of set the impetus for the research that I've been doing. And the pattern really was around the fact that people were kind of being referred to clinical therapy, but they were referred after having exhausted a number of kind of different health professional medical investigations. So they're having all of these workups, they were getting all of these investigations to try and figure out why they were not feeling so great. And all those physical workups were coming back and showing that there was really very little there. And it was really then at that point that the general practitioner was saying, well, maybe you should go and have a chat with a psychologist. So, you know, they were coming to mental health services really at the end of their help seeking journey. And, you know, that was kind of where I started thinking as a researcher and as a clinician, well, you know, is there research to kind of demonstrate why this is happening? You know, why are they kind of coming at this right at the end? And, you know, when I turned to that research, well, I found very, very little at that time. Again, like, before I go into the research, I'll just talk a little bit about some of the concepts that are related to my research. The first concept is defining who is a refugee. And I guess I don't know who the audience is. Some of you might be quite familiar with this. But, you know, a refugee is a very kind of strict term. It was coined by the United Nations in 1951 and, you know, has a very strict definition. And it's a person who has been exposed or has a well-founded fear of persecution because of their race, their religion, their nationality, because they're a member of a particular social group or they have a political opinion. In addition to all of that, they need to be outside of their country of origin, and they need to be demonstrating that if they were to return to their country of origin, then they would be at risk of serious human rights violations, such as, you know, being imprisoned, being killed, having a family member killed, and so on. And it needs to be related to those reasons. So you can see that it's quite a strict and very tight definition. And many people will have been exposed to a lot of these things, but may not necessarily always meet the criteria to be able to define themselves as a refugee. This slide, I think, is really important because for many years now, I've been kind of presenting my research and, again, setting the scene in terms of numbers worldwide. And what I have found, and I start off, when I talk about this research, this slide, as I always say, refugee numbers are dynamic and will go up and down depending on whatever conflicts are occurring around the world and what have ceased. But I have noticed over a number of years now that these numbers are not going down. And in fact, they're going up at a very high and alarming rate. One of the kind of figures that is really confronting is the fact that the number of forcibly displaced people, so that total number there, equates to 1 in every 69 people globally. So that's huge. And then if we think about how many have met the criteria for being a refugee, have demonstrated that and have been mandated as refugees, that's 43 million, 43.4 million approximately. So that's really tripled since 2013. The other thing that I talk about from a mental health perspective is that refugees are often seeking asylum in nations that are considered, you know, low income or middle income themselves. And that really has significant implications for their needs assessment and how they're met in terms of their health and their needs. So hence why we've been interested in understanding the mental health outcomes of this group. So this slide is really important because it also talks a little bit about who have been kind of being resettled in Australia for a number of years now. And what it demonstrates is that the top 5 countries that have been given humanitarian visas, so the top 5 countries of origin that people have been given humanitarian visas in Australia are these 5 countries. And it really hasn't changed. So, and it's interesting because this is also, except for Myanmar, these are the groups of people that I have been doing a lot of research with. So people from Iraq, those from Syria, those from Afghanistan, and more recently I've done some work in those from the Democratic Republic of Congo. So by the nature of their definition, refugees are more likely than most people to be exposed to what we call potentially traumatic events. And potentially traumatic events, these events can occur both before, during, and following their displacement from their countries of origin. And this is why we're so interested in understanding the mental health outcomes, because we know these are quite significant impacts on people's mental health. And they feature around these 3 categories. So those that are kind of related to violence, those that are related more so to deprivation or you know, being deprived of certain things, and those that are related to loss. And we know that being exposed to these potentially traumatic events can have a significant impact on a person's health and well-being. And so what does that then lead to? Well, research has shown that they are more likely than, say, community samples of host nations to have what we call post-traumatic stress disorder, well above the community sample rates, to have depressive disorders, again, well above that, and to have other mental health conditions, although there is probably less research around that, again, because of the nature of the communities. And we know that being exposed to traumatic events and having these mental health conditions is something that is very, I guess, normal. We would expect this. And so we've been researching this and understanding this more and looking at this. But I always say when I'm presenting this research that, you know, we may be kind of doing these measures and looking at rates of PTSD, looking at rates of depression, but I think it's more than that. I think we need to be counting the impact it's having on the communities, on societies. So, you know, in these collectivist communities, it's not just about the individual, it's about all of the other kind of flow-on effects. So we know that there is a lot of research to show that, you know, children sometimes in families will take on a premature caring role. There's a breakdown of family trust. There's sometimes increased rates of domestic violence. And, you know, there's communities start to lose their identity. So the costs of this kind of exposure to trauma, I say always, is not just counting things like PTSD rates or counting depression. It's more that. It's looking at the kind of impact it's having across the communities. Oops. So, as I said, when I started this research, it was really spurred from that kind of anecdotal clinical observation that people were attending treatment well after having exhausted so many different kind of pathways. And so pictured here was some of the initial research that we were looking at. And here we were just interested in documenting, you know, what is the difference between those seeking treatment, those not seeking treatment, you know, looking at kind of rates of mental health conditions and so on. And what we found was indeed that there was probably very little to distinguish between those seeking treatment versus not seeking treatment. And sometimes, in fact, those that were not seeking treatment were, you know, kind of demonstrating some more concerning findings, which then kind of made us think about, well, it's clearly a need to understand why it is that people are not seeking treatment. And so this is where we turn to the concept of mental health literacy. So for many years now, we've had very good evidence to suggest that if people seek treatment at an early point and at the substantial level that they need, then their outcomes are going to be better. But to engage in treatment, we really need to have some understanding of where to go and what to do. Okay, so that's basically that concept of mental health literacy. And mental health literacy was first coined by Professor Tony Jorm in the kind of 90s and his colleagues to refer to knowledge and beliefs around mental health conditions or disorders that can aid their recognition, management, and prevention. And so it ranges from a whole variety of things, but you can see that these are kind of the core concepts. So recognizing specific disorders, so the ability to recognize it, all the way through to knowing how to seek, you know, mental health treatment or mental health information. Now, since his seminal work, Australia has really gone on to become a world leader in mental health literacy. And this research, his research and others that have followed on, has been used with encouraging results to form all of these kind of public health campaigns. And we've had organisations created, things like, I don't know if people have heard of things like, you know, mental health first aid. We also have an organisation, a peak health mental health organisation called Beyond Blue in Australia. And that these organisations have delivered these kind of interventional programs in the community or public education programs. And they have focused on trying to improve people's attitude towards mental illness, to increase their kind of early intervention so that they will seek help seeking when they need to, and to develop kind of some skill base to encourage prevention of people going further down the line and developing mental illnesses. So what has been the outcomes of all of these public campaigns? And so here are some of the kind of research that Tony's group has done. And what we've, you know, found over the years is that when they did a mental health literacy survey across the kind of the nation, there's been an increase in recognition of mental health conditions. So you can see over the years that people are increasingly recognizing some mental health conditions really quite well. And there's also been a decrease in some of the kind of negative attitudes. So one of the kind of key things that we think about when we're talking about negative attitudes is stigma. And stigma itself is quite a complex kind of concept. It has different parts of it, but one of the kind of key parts is the belief that people who have mental illness have a weakness in character. And so they've measured that and seen that over the years that, you know, that belief has slowly decreased over time, which is really encouraging and demonstrates to us that if we undertake these mental health intervention programs or education programs, we can improve the community's kind of mental health literacy. And so this kind of was where myself and my graduate students were at. And we were trying to ask the question, well, what do we know about mental health literacy of refugee communities? And it turns out that prior to 2014, there wasn't really a lot being published. And this was despite the fact that when I was trained as a psychologist, we knew at a clinical level that different communities have different cultural perceptions of mental illness, and therefore that perceptions will impact how they engage in treatment. So at that clinical level, that was not known, but it wasn't really being kind of thoroughly kind of researched at that kind of evidence-based level. And that was really where we started to do our mental health literacy research. So pictured here are a few papers where we just started looking at the mental health literacy of different kind of refugee population groups. And I guess to summarize in a nutshell, what we found was, what was expected, that the recognition of mental health conditions was low. And this was despite the fact that we were going in and asking them questions about mental health conditions that we knew were very prevalent in the community. So we were asking things about post-traumatic stress disorder. We were asking questions about depression. And people not only were not able to recognize it, but they were often misattributing it to something else, like a physical condition or just, being lonely or homesick or something like that. We also found that help seeking was really low. And this was probably really quite concerning because in addition to surveying their mental health literacy, we were also administering some kind of basic symptomology measures. So we were looking at the group in terms of how they were performing in terms of PTSD and depression. We were finding that people who were answering these surveys actually had very high levels of PTSD or depression, but yet they were reporting that they weren't seeking help. So this really kind of started to make us think about, well, what can we do? So if we know that mental health literacy is quite low in these communities, we've demonstrated this, what are the next steps that we can do? The first thing we started to think of was, well, what is the help-seeking barriers, And so this comes from not only my research, but other people's research. And generally speaking, we can think about barriers to help-seeking, particularly around mental health we're talking about, across two kind of domains. The first is related to structural barriers. And these are very simple things like, they may have limited access to transportation. The financial cost of mental health treatment is quite, prohibitive. They may not have the language skills to be able to seek help. They may not have trust in mental health services because, there'll be limited kind of mental health clinicians who can practice within their kind of culturally safe domain. Or there may be a distrust of the clinicians, or it might be related to confidentiality. Again, so maybe there may not be the clinicians who can practice in the language group, so they bring in interpreters, but there's a lot of kind of distrust of using interpreters, particularly around privacy and concerns around that. So those are structural things. The other thing we also demonstrated, and that was related to more around mental health literacy, again, so that recognition and that need to kind of seek help was not there. So these are the two primary barriers. Now, clearly, as a group, we probably can't, without quite significant support systems, do a lot of work in that, eliminating structural barriers. But we started to think about, well, what can we do about targeting these mental health literacy barriers or health belief barriers? And this is where I have been working in for a number of years now. So here are some of the publications which have reported on the evaluations of different mental health intervention programs. And we have worked not only within the community itself, but also the support systems around the community. So probably very similar to the US, when people come in as refugees or new arrivals, there's a whole series of support systems that are put into place. They are given access to language tuition programs. They're given access to community support workers. And a lot of that systems that are around them is very important. But what we also found was that those systems, those people like the tuition language program teachers or the community support workers themselves, they have very little mental health literacy themselves. So we were kind of looking at what can we do with that group of people. And in the case of the young new arrivals, the high school teachers were also, demonstrating that they also needed some support. So one of our first intervention programs was to take the mental health first aid program. So here I got to work again with Tony and work very closely along with my former PhD student, who's a graduate now and postdoc. And we took the mental health first aid program and we tailored it. So it would be appropriate to those who are working with resettling Iraqi refugees, because at that time, they were by far the biggest bulk of people that were coming into the country. And so when we took this program, we tailored it, we then delivered it to these community workers, these language tuition providers, and we did a pre, post and follow-up. And we found that at that point, post and at follow-up, we were able to demonstrate that not only were there recognition of those workers increasing, so we're able to recognize, yes, this is a mental health problem. This is not someone just being disruptive in class. This is a sign that this person perhaps is having something like hypervigilance. They're not just getting up for no reason. So we were recognizing those things, but also we were also able to demonstrate we were reducing stigma towards mental health. So we were reducing their kind of belief systems that things like mental illness is perhaps just this person being disruptive or weak or so on, and improving their confidence to be able to respond appropriately. So, how could they then provide the help to get the person to seek, professional mental health support? And most, importantly, we were finding that these findings were being maintained through, 6 months at follow-up. So that was really quite good. Again, the next program we did was we again worked with mental health first aid. And this time, like I said, we tailored it to young new arrivals. So we had a very large influx of new arrivals coming in post 2016, 17, mostly in those kind of high schools in Fairfield area. And we were finding that there was quite a big need amongst the high schools for delivering some intervention for not only the students, but also the teachers, the front house office staff, and so on. So we delivered a tailored version of the teen and youth mental health first aid program. And then again, we did a pre, post and follow-up. Before I show you the results, the other thing I'd like to say is that all of these tailored programs are now available in the suite of different mental health first aid programs you can arrange training in. So if you contact Mental Health First Aid, you can pull up these programs. So the findings here, oops, just gone too far. Oh no, I haven't. Okay. So what we found here was that, again, we were able to improve knowledge, not only of the young people themselves, but also increasing the knowledge of the teachers. And most importantly, increasing the knowledge of the teachers on what to do, how to intervene when someone's presenting in crisis, how to then get them to seek the help and where to seek the help. So again, like I said, that was a wonderful thing because we were able to demonstrate that this was maintained at follow-up. So then we moved into working with the refugee communities themselves. So this is a different kind of program. So they're no longer working with those that support them, but working within the community themselves. And so this was a program that was delivered in partnership with New South Wales Refugee Health Service. So this is, again, a statewide health service that's provided to people who come in under humanitarian visa. And it was a program that kind of was informed from all of the mental health literacy work that we had previously published in. So we created the curriculum to target the areas of deficiency that we found. So, not only do we kind of focus on improving their knowledge around common mental health problems, but we focused on kind of reducing stigma. But we also focused on improving kind of understanding of how to seek help. The program was very much co-produced. So when we were creating it, not only did we use the evidence from our previous publications, but we worked with the community members themselves so that we ensured that the program was going to be culturally sensitive, that it was going to be interactive, because people don't want to just listen to us talk to them all the time, but they wanted to do some interactive activities. And very much we were focused on trying to make sure that we were mindful of what the community's beliefs were. So having said that, though, we were trying to bridge those two. So a lot of things, for example, might be not necessarily exactly the same as our kind of biopsychosocial model of treatment in the Western world, but recognizing that there is the ability to have this duality of treatment beliefs. So, and making sure that we were mindful of that. So this slide kind of gives an overview of the curriculum in this program. So as I said, we were looking at increasing their knowledge around mental health and well-being. We were looking at talking to them about some of the common mental health problems and illnesses. So, defining what is PTSD, defining what's depression, but, in proper, very simple language that was appropriate for our community members. We were looking at really targeting stigma, those belief systems that kind of underpin stigma, and then helping them understand how to seek help in the Australian mental health care system, because it is quite a cumbersome system. So navigating, the mental health system in Australia was something that we really wanted to make sure people had a clear understanding of. But then most importantly, it was the self-help strategies that were, I think, one of the things that kind of set it apart. So we weren't just intervening and increasing mental health literacy, we were also developing some skills amongst the community participants. So things like developing understanding around sleep hygiene, providing the ability to do some mindfulness exercises, everyday actions to promote well-being. These were really kind of important factors that we wanted to kind of develop in these communities and the people who are attending this program. So the program itself was evaluated and it was published as well. But I just want to draw your attention to some of the kind of key findings, or the most striking findings. What we found was that, as I said, stigma or negative attitudes to mental illness is quite complex a concept, and it has a number of different components. So aside from that belief that, it's a weakness of character, there's another kind of component which is called social distance. And that is where people, for example, want to have a distance between themselves and those with mental illness, or a postulated person with a mental illness. And so what we found was pre the training, it was quite high. Post-training and at follow-up, we were able to reduce this kind of level of social distance, which was really fantastic. But even probably something more really good and unexpected, I guess, was that we were finding that when we were taking measures of psychological distress amongst the people who are attending, a very high proportion of those who are attending the program were ranging in that kind of very severe psychological distress. But post and more importantly, follow-up part time, we found that really reduced, and it was significantly reduced. So, it indicated to us that coming in with these kind of very simple self-help strategies can really help people, even if they don't go and further, seek further treatment and go into professional help seeking. Even just delivering those self-help strategies can really, really be important. In addition to kind of doing these evaluations, we also did some qualitative interviews or qualitative kind of questionnaires, and we were asking them, well, what do you think was helping? What do you think made this program unique, and what did you like about this program? And some of the things that they reported was that we were respectful, that we allowed them to understand that you can have both the duality of treatment beliefs, as I said, that we were mindful that they're not just the individual, but they are also part of a big kind of system in place, so that kind of prioritizing collectivism over kind of individualism. And that's really, really important, because in Australia, and I think probably in the US, I certainly know in the UK, as mental health clinicians, we are very much strongly trained in what's called cognitive behavioural therapy. And cognitive behavioural therapy very much is focused on the individual being the agent of change. So the individual may have particular types of thinking patterns which are not conducive to helping them in terms of the way they view things. So having that kind of individual as the centre or the agent of change doesn't necessarily ring true in these communities where there are much more kind of a collectivist type thinking. So, working with them to try and make them kind of breach those two belief systems was really important. And also, emphasizing that spirituality is often very important to these communities, and acknowledging that was really, really important to their engagement in this program. Now, while we were doing this program, another thing that really came out, and it was not something that I had worked in, but it was another Australian-based researcher. She was a postgrad student who then at that time did a bit of mental health literacy surveying of religious leaders in Sydney, so based in Sydney, across all different denominations. I think it was mainly focused on Arabic-speaking religious leaders. And what she published and found was that the levels of mental health literacy amongst religious leaders was quite low. And again, not too surprisingly, because most people who are not trained in mental health might not necessarily have this kind of additional skill. But it was really important at that point that we needed to intervene, because we recognized that religious leaders not only are the gatekeepers within these communities in terms of accessing the communities and kind of delivering kind of trust to do different things, but they themselves are the first point of contact, often for families who are in distress. So, upskilling these religious leaders was really important. And this then led to this kind of last program that I want to talk about, which was intervening with religious leaders. So Arabic-speaking religious leaders, and basically kind of developing not only their skills around recognition of mental health conditions, so, mental health literacy, but also kind of developing their skills around what to do and where to refer on. So this program basically was delivered in a one-day seminar, because there were often, people who you couldn't get in to come in multiple times. And we focused again on, like I said, knowledge, but also tackling stigma. But more importantly, developing their confidence to be able to support people in crisis, and then also move them to the appropriate services that need to be, talked about, and where the person needs to go. The findings were, like I said, evaluated. We published those findings as well. But just, a quick summary here was that when we looked at knowledge, we were able to significantly improve that, which was fantastic. We were also able to kind of improve their knowledge around treatments and align their treatment beliefs around what's available in the Australian-based system. And we were able to reduce stigma, which was good, and that was at a significant point. But very importantly, we were able to improve their quality of help-seeking advice. So, giving them the confidence and the tools and the resources to deliver the treatment advice or the help-seeking advice to those families, so that they could then seek professional mental health treatment. Okay, so this is kind of where I'm going to stop talking a little bit about my own research and move over to change tracks, talk a little bit about myself, I guess, first, and then some of the kind of tips and strategies that I've had over the years. So I guess just to briefly summarize, I am an Assyrian, a proud Assyrian Australian. I'm the eldest of 3 girls. I was born in Fairfield, which is, like I said, the most diverse, culturally and linguistically diverse region in New South Wales, certainly probably across Australia, and the biggest population group of Assyrians residing there. And it's an area that I continue to work in as a psychologist and continue to do a lot of research in. Pictured here is my father, who's holding me. So Isho, he came to Australia in 1969. He came from Iraq. He was the first in his family to migrate to Australia. And he came to Australia after actually his cousin came to Australia and wrote to him, because back then he'd write letters. And he wrote to him and he said to him, "Oh, Australia's fantastic. You need to come here. We've got lots of swimming and fishing and all these outdoor things that he loved." So that was it, was sold for him, and he came straight to Australia. But before he came to Australia, he had travelled to Syria, which is where my mum comes from. He was visiting family there. He met mum. And then a few years later, mum came over, they got married. And then I was born and my sisters were then born. So when I grew up, I remember mum and dad were very much about, kind of having a typical 70s childhood. So I'm kind of giving away my age here, and pictured here is my beloved pet dog, Rusty. I remember being outdoors all the time and doing all those fun things that probably you never see kids doing much nowadays, unfortunately. But my parents also very much stressed the importance of maintaining our traditions and our customs and our language at home. And when I was around about 7 years of age, I was lucky enough to go back to Syria to visit my mum's family and to visit my father's family in Iraq. So that's another image of myself with my cousins in Syria. So like most migrants, my parents came to Australia to seek a better life. And they did that. So, they both, further trained, and my dad was an industrial chemist, and he continued to work for many years in his early part of his career in a petroleum company here in Australia. And but they were very, like I said, very, very much about, speak the language at home. We weren't allowed to speak English at home, which I think at the age of around 7 years of age, I thought was really, really annoying, because why couldn't I? All my friends were speaking English and I couldn't speak English. And I have to admit, it was a bit of a nuisance. However, I really thank them wholeheartedly now, because it certainly enabled me to have a strong enough command of my language. Not really, really strong, but certainly at a conversational level, and certainly at a point where I can do therapy in. So, this emphasis on bridging the two cultures was introduced to me really, really early on. And I guess that's always been in the mindset of mine, even, and so when I came to do this research, it was something that I suppose was a very strong framework that I could apply in my research. So I'm just going to now move over to, I guess, some of the important lessons as an academic, as a female, and a female from a minority group, no less. And I guess nothing on this slide is completely revolutionary or new. It's certainly things I'm sure that people have looked at and thought about or read about. But I guess the most important thing is, how do you apply it? How do you take this framework and apply it? And each person will apply it in different ways. And it will, much more depend on what is around you. But, so the first bit, so on the right hand of the slide, we've got all of those lessons that are more directly related to career. But I think underpinning success in career very much relates to what's going on in your own personal life and some of your own personal attributes. So I'll talk a little bit about that. I think most of us have always kind of had cognizant of the fact that there needs to be a good work and life balance. And that's really, really important, and I guess when you think about that, you think about it as an individual, but we in this community, I'm sure most of us will be very, very familiar with this. We're not just ourselves, we're part of a larger group. We're part of our family group. We have family expectations, we have cultural expectations. And so there is that added kind of layer of, I suppose, complexity, but with complexity is also some, wonderful strengths as well. And I suppose when you think about it, how do you deal with that? How do you deal with that expectations while kind of working in this very demanding field? And I don't think I've come up with a tried and true solution. I think it just kind of works a little bit differently for people. But I found that it is by far the most important thing is communication. And I think in my own personal life, there's been lots of times where I've had to flag to my, husband or my daughter, I've got a very impending kind of deadline coming up. I'm going to have to be a little bit selfish for the next week or so. But, post, the deadline, I'm going to, be able to contribute a lot more. So I will then pick up a lot of the other slack and give them a bit of a break. So this communication is really, really important. And I'm aware that there are some things that you can't reschedule, but I think, working in that kind of communicative strategy is really, really important. I also think that one of the other important things has been that, when you work in academia, as I said, it is quite a complex situation. You often got these really tight deadlines. And so it can be quite challenging. And I suppose I've always tried to use a framework of looking at things as being, kind of in a curious way or very creatively. So trying to think of things rather than being challenging, looking at the process of learning and growing. And I suppose this is really, really important, because that allows you to no longer see things really in a kind of negative space, but more as a kind of, well, what can I gain out of this? And then probably very, very importantly, and this is something that we all probably at some level have, or else you wouldn't be in academia, the level of tenacity. So you really almost have to have this stubborn-headed level of tenacity, the ability to keep going with something, even though sometimes it seems like it's all but the other way around. So, like you just want to give up. You just got to keep going with something. So just be constantly mindful that, it is that level of being able to stick to something, and resilience, picking yourself up time and time again is something that you will probably realize is really, really important, at that level of a personal, but also in your career level. Moving over to the career perspective, I cannot emphasize enough the importance of mentorship. And I think we all recognize how important it is. And it's certainly very formalized when we're postdoc or PhD students. So you have that formal kind of mentor or advisor relationship. But I think it needs to be maintained. And that's just something that I have found has been really important. So beyond graduating and becoming more of a senior academic, I still think that having a mentor is really, really important. So you may not go to them for the kind of day-to-day advice, but you certainly having a really senior mentor in your life will be really, really fundamental to being able to give you strategic advice, to say to you, this is where you need to put your efforts in, this is where you need to pull back. So I cannot emphasize how important that mentorship and maintaining mentorship is. Collaboration is really, really important. I found that some of the most useful lessons I've learned has been working in large teams, and not all lessons have been fantastic. Some of the lessons have been, things that I've learned to never do again, but having teams and teamwork is really important. I recognize there are different fields who might not, value collaboration as much as health does, but if you can get into a collaborative kind of teamwork situation, that's fantastic. As academics, we are expected by our communities and our students to stay current to knowledge, and it is something that we're constantly having to maintain our knowledge. So having a lesson plan or a learning plan of continuing to be an expert in particular areas is really, really important. This is what will continue to set you apart. So developing where you would like to learn more about and continue to learn about is really, really important. Authentic leadership. So this is something that you might think, well, as a graduate student, I'm not a leader yet, but I say to students, think about who you want to be, and think about when you go forward in your career, what you want to be recognized as. This has really been something that has been central to the way I approach most things. To me, authentic leadership is that you lead in a way that's aligned with your personal values and beliefs, that you do things that are really meaningful to you, and that they match your passion and your purpose in life. So for me, it's always been that whatever work I put my time into, it's got to be matching the values that I believe is really, really important. And as an academic, like I said, we're not only the custodians of knowledge, so we will produce knowledge, but we need to be thinking of the next generation. So making sure that we are leading our students, we're leading, our postdocs and so on, to be, knowledgeable, but to be empowered. And the way you do that is to be flexible and responsive to their needs. And finally, I'd like to talk about the last one, which is to celebrate wins. So I've already kind of maybe alluded to, and I'm sure you're probably very much aware of, academia is not for the faint-hearted. We're constantly putting ourselves up for critique, while we might be told, this article is not you, it's your article, it's still very personal to us. So constantly getting critique it can be daunting. And although, like I said, you can treat it with that kind of creativity and curiosity and learn from it, it still nonetheless can sometimes be quite difficult to accept when you have put in so much effort and it's told that it's not quite good enough and you need to resubmit or so on. So when the wins come, I say celebrate them, because they are so far and few between, but there's certainly things that will be very, very mindful in your mind. So you need to have them constantly at the forefront of your thoughts. Finally, I just want to kind of talk a little bit about research. And so how do we develop research proposals? And I mean, again, like I'm coming at this from a health perspective, but I'm sure it would apply equally to all disciplines. And I think one of the most important things is that when you're doing research, the research needs to be essential and of significance to the beneficiaries, the communities that you're working with. And it doesn't matter what model of research you're doing. I always think about, well, what is it, the end goal? I mean, sure, there is some pieces of research will just deliver knowledge, but really, is this knowledge the next that would be used as a fundamental stepping stone? Then that's fantastic. The other thing is that you need to think about, well, what are the outcomes that are going to come out of it? So everyone has different outcomes in mind. It's around health, but trying to develop and improve outcomes is really, really important. Dissemination of research is always something that's very much certainly something that's stressed to us here in the Australian public research space. So we can publish articles, we can go to academic conferences, but that's not enough. Often that stays within our groups or our peers. We need to engage with policymakers, we need to engage with administrators, we need to, in my case, engage with clinicians. Those are the people who are going to take this research and deliver it so that it becomes real kind of impactful outcomes. But even more importantly, the communities that we're working with. So often I will work in that space to ensure that whatever findings I have, I can feed back into the communities so that they may want to take that research and develop different kind of plans. And then finally, I think, certainly in the area that I've worked with, there are certain populations that are sometimes overburdened, and then themselves are quite vulnerable populations. So that's why I stress that collaboration. So working in kind of team spaces enables us to do research, but not to overburden those particular populations. So, that's always fundamental to me when I'm thinking about, what next steps of research I'd like to do. And then I'm just going to quickly talk a little bit about a new project that I've been working in, which is I am just about to start writing up the findings of. So this is a project which is really, really something that's very close to my heart. I was interested in looking now specifically within the Assyrian community. So I was looking at the concepts of loneliness and mental health and attitudes to historical losses. It is only based in Australia, and it's been, the survey's been up and running for a number of months now, and we've got quite a good intake, uptake of the survey, and I've been able to, get quite good numbers. But I am interested, if people are interested in potentially, having international kind of surveys of Assyrians as well. So I'd like to end up by saying, if you are interested in kind of looking at a new collaborative project, this might be something we could talk about. And to just acknowledge all of the people and the funders that have allowed this research to take place, because you do need a lot of support when you're doing this research. And to say thank you very much. This is my email, and I am very interested. I imagine not so much for supervision, although I have supervised a PhD student once from the US, but not as a primary. But certainly I'm very interested in potential collaboration. And that's it. Thank you.
Thank you, Dr. Slewa-Younan, for your presentation. It was extremely insightful, especially getting to understand your research on refugee mental health and how impactful it is, the work that you're doing, and also the insight you're offered for grad students. I do want to mention, if you want to go back to a few more slides, back to the slides where I have that QR code, just in case people want to have that opportunity to take an image, I guess, of the QR code to fill out the survey. So now we're actually moving on to our Q&A portion of the webinar. So there are some questions that I'll definitely be reading out loud, but if you have any questions that you'd like to ask, please go ahead and submit that. We do have a few minutes left to go over them, so let me just put on my glasses because I cannot see that far.
Sorry, Alexander, can I just point out that this is based in Australia, so the people that would be completing this would really need to be Australian-based Assyrians. So hence why I'm interested in potentially. And there's nothing stopping me from then expanding into other locations of the world there are Assyrians. But why I would like to have some collaborative kind of potential outreach in that respect. But if anyone is in the audience is from Australia, by all means, please take. I'll be very happy for someone to take this survey. Or if you have family members that you can then say, hey, by the way, have you seen this research? Please, very, very happy for people to complete the survey. Thank you.
Of course. So we'll go ahead with our first question. So did you find a difference in the mental health needs of refugee women compared to refugee men?
Yes, so some of the early papers that we looked at mental health literacy and mental health outcomes, we weren't looking at, were men or women more severe in terms of their levels of PTSD or depression, but we certainly looked at the way that they were engaging in services and what were some of the kind of barriers and belief systems. And we were finding that there were differences. I mean, as I said, these communities are very much collectivist communities, so that applies across both genders. But I think with women, there's an added level of, family and all of those things that further kind of impact on it. We found that sometimes, seeking services or seeking help was sometimes, I wouldn't say gatekeep, but that there was an added complexities for women, that they needed to go through particular kind of maybe their husbands or their fathers, and it depended on the community. So for example, in some communities it was more so than others. So even though I've said Iraqi refugees, we were looking at, for example, maybe dividing them across different religious groups, and it was more so in particular religious groups. Yeah.
Okay. Have you ever run into ethical constraints that reduced your research on refugee mental health, and how did you overcome them?
Yeah. Very much. Well, yes, because when I first started doing this research, I remember, putting in my first ethics application, and as I said, Western Sydney University has been a very new university, and I kind of came in halfway through their journey. So I was, I've been there for 15, 16 years. So they were still starting to find their way around things. And I remember, as soon as they saw the word refugee and mental health, they were like, wow, this is going to be, we're going to have to take this up to a much more level of scrutiny. I guess it's been something where I have worked with my ethics team. So we have both. I suppose I've upskilled them and made them understand more and more some of the kind of things to be concerned about and things not to be concerned about. And I guess also what has assisted them has been the fact that, although I am working with vulnerable communities and I am working in a space that is potentially, again, another level of vulnerability, mental health, because I come from a mental health background, I work in the community, I was able to kind of develop really quite clear, distress protocols to demonstrate to the ethics community, if this were to happen, this would be then engaged into, and we would do this, this, and this. So it has been a learning kind of curve between myself and the ethics committee, but I think we've managed to circumnavigate it over the years, and to now I have a really good relationship with the ethics secretary here at the university, and it doesn't mean things go really smoothly, but it's really easy to kind of reach out and say, okay, well, if you're concerned about this, we can do this and this. So I guess it's just working together. And identifying where are the points that are kind of being barriers and finding solutions around them.
So this is kind of there's two questions within this. So first is actually a compliment. So Professor Slewa-Younan, your work is incredibly needed. I'm also inspired by you. My question relates to a really important point you raised about stigma and mental health. And I feel that most Assyrians and people from the SWANA, SWANA, region more broadly struggle in this domain. What on community level can you do to reduce the stigma? Can we talk about the mental health in a productive way that normalizes it as a concept?
Yeah. Well, a lot of that work that I've been doing in that second half of my work, which is, developing those programs, has really kind of been, like I said, two-pronged. It's been aimed at, increasing mental health literacy, and mental health literacy stigma sits within it. So developing knowledge around mental health usually allows people to then recognize that mental health, just like physical health conditions, is something that people can experience through their lifetime. We normalize it, and we demonstrate that it's treatable. But often all of these conditions can be treatable, and people can go on to have very, very effective and productive lives. So yes, I do think we can intervene in this in our Assyrian community. I do agree that there is stigma. However, I think the stigma in the Assyrian community is probably no more greater than most refugee communities. I think it's just a matter of maybe just tweaking the way we intervene so it's appropriate to the communicating the messages that are appropriate to our community. And I am mindful that in our community, again, I think we have particular leaders that are important, so gatekeepers in our community. And I think religious leaders are very important. Whether we may agree with this or not agree with it from different kind of points of view, we can't neglect the fact that they do play a very important role. And again, working with our religious leaders, and I've had a really good I've been very fortunate to have developed a good relationship with some of our religious leaders over years, and had them involved in a lot of the training programs. So I think we need to intervene with the community themselves, but we need to intervene with the support systems in our community as well. So I don't know if I've answered the question very well, but I hope that's gone towards that.
No, I think you did. So I think we have time for one more question. So you mentioned tenacity in your presentation, and I resonate with it very much as a graduate student myself. I was wondering if you can discuss ways in which tenacity helped you along your academic journey from transitioning from a grad student up until being a scholar, and a researcher and having all these publications, and whether or not it actually allowed you to sustain your research and your interest in the specific field.
Absolutely. I mean, I think my parents recently moved. I know this is a bit of a left of field kind of, but I'll come back to this. My parents recently moved from the house that they've been living in. So the house that I grew up in, they'd been living in it for more than 40 years. And they had this basement, which ended up being where we put everything in there. And we were dreading kind of moving all the stuff in the basement, but it was really quite good because I just recently, it was about 3 weeks ago, we had to pull everything out. And I found my report cards from when I was in primary school, which I don't know what you guys call. So, when you're in, year 1, year 2 of your, early years of education. And I remember reading it and I saw the word, this is a very tenacious student. And I was like, wow. So I was demonstrating this right at the beginning. And it's funny because, in fact, as I said, my parents were very kind of very, very focused on making sure that we spoke Assyrian at home. And so I was the eldest, and I was an eldest I was an only child for a number of years before my siblings came along. So it was just myself and my parents. So actual fact, when I went to school, I didn't speak a lot of English, despite having been born in Australia. So I had to be put in those specific kind of extra language programs. And I remember kind of reading my thing saying, oh, well, she's picked up the language skills really quickly, and she's, really, really tenacious with her focus. So I think it's always been something, but I'm not saying that it can't be cultivated. I think you can. And I remember listening to a podcast recently about, some of the kind of determinants of success are not necessarily levels of intelligence, but more so kind of attributes, and tenacity is something that's always been one that's been found over and over again. I guess it becomes easier when you do something that really rings true to you. So if you and I have found over the years that I am more likely to say, no, I'm going to keep doing this because it's so important to me, than if I'm doing something that's not important to me. So I guess finding your niche, finding where it's something that is really true to you, and working in that space is so important, because it then means that it's not just about that academic exercise anymore. It's about, something really meaningful. So I guess, I don't know if I've answered that question, but, I've been doing different research over the years, but it's only when I kind of combined my clinical and my research together that I found my true kind of really strong niche. And it's since then that I've really found that my outcomes have kind of really upped, because it's been something so important to me, I guess. Yeah.
No, thank you for asking, for answering our questions. So we're now we reached the end of our webinar, unfortunately, but I would like to thank both Dr. Shameran Slewa-Younan and our attendees for joining our webinar for today. And Dr. Slewa-Younan, your research and the experiences you shared with us today have really been incredible, and especially enlightening and inspiring, as I mentioned a little bit previous. Your dedication to advancing mental health literacy and supporting cross-cultural communities is truly commendable. And I thank you, and I know everybody who joined our webinar found it very insightful, and possibly gain new perspectives that will, maybe encourage them to go into the field of psychology and so on and so forth. We hope you all found this webinar really helpful, and we hope to see you at our next event. Thank you, everyone.